In this presentation, we're going to discuss thyroid eye disease, and specifically at the end of the presentation, special aspects of thyroid eye disease related to strabismus surgery. With regards to the epidemiology of thyroid eye disease, and epidemiology is the study of the determination of the distribution and determinants of diseases, it's an uncommon disease with an incidence of about 19 in 100,000 per year. It's most frequently associated with hyperthyroidism in about 90% of cases, with hypothyroidism and a euthyroid state present in about 5% each. In some cases related to Hashimoto's thyroiditis. About 50% of patients with thyroid disease will actually develop thyroid eye disease. There's a higher prevalence in women than men, though the course in men tends to be more severe. And the median age of onset is 43 years, with a reported age range of 8 to 88 years of age. The prognosis tends to be worse with a later age of onset, and pediatric eye disease relative to adults is usually milder. Smoking is the most consistent environmental risk factor related to thyroid eye disease. And although children may have proptosis and lid retraction, as seen in this case, it's unusual for them to have strabismus or compressive optic neuropathy. And note the thyroidectomy scar in this child on the right photo. Thyroid eye disease is an autoimmune disease where autoantibodies lead to activation of orbital fibroblasts, which can differentiate into adipocytes and myofibroblasts, which produce extracellular matrix molecules and glycosaminoglycans, which bind water and lead to swelling and eventually fibrosis of the orbital tissue. Hyaluron is the chief component of the extracellular matrix. The pathophysiology is not completely understood, but appears related to a loss of immune tolerance to the thyroid-stimulating hormone receptor and the recent recognition of the role of overexpression of insulin growth factor 1 receptors. Inflammatory cells also stimulate fibroblasts to secrete glycosaminoglycans, and cross-reactivity of antigens in the orbit and thyroid gland lead to an immune response in each. These are the symptoms that you should be asking about with thyroid eye disease: a gritty sensation, photophobia, tearing, dryness, eye redness, proptosis, double vision, and blurred vision. And on examination, you'll want to look for eyelid retraction, lid lag of the upper lid and down gaze, which is referred to as von Graefe's sign, eyelid edema, proptosis, conjunctival injection and ecchymosis, and exposure keratopathy. Eyelid retraction is one of the most common findings present in up to 90% of cases. So the margin reflex distance is a way to measure eyelid retraction. Well, a typical corneal diameter is 12 millimeters, and a normal upper margin reflex distance, or MRD, 1, for the upper lid would be 4 millimeters. And the lid usually covers the top 2 millimeters of the cornea, so a lid at the upper limbus would have an MRD 1 measurement of 6 millimeters. In this photo, the MRD 1 measurement would be about 8 millimeters in the right eye and 9 millimeters in the left. Since the upper lid is about 2 millimeters above the upper limbus in the right eye and about 3 millimeters above in the left. The lower lid usually rests at the lower limbus, so the MRD2 would be about 7 millimeters on the right side and about 6.5 millimeters on the left. The Hertel exophthalmometer is used to determine the axial position of the eyes. The instrument is placed on the lateral orbital rim of each side using as small a base as possible. And depending upon the device, the lines on the prism are placed into position by moving the examiner's view point to determine the measurement. The measurement for the patient's right eye should be determined with the examiner's left eye and vice versa. The device measures the distance between the lateral orbital rim and the most anterior portion of the cornea. In general, measurements between the two eyes should be equal. If the measurements are different by 2 millimeters or more, the patient should undergo additional evaluation. The upper range of normal varies by race and is about 20 to 22 millimeters for whites and 23 to 24 millimeters for blacks, and so does vary by population. Well, the gold standard for measuring proptosis is a scan, such as a CT scan, where the exact distance from the lateral orbital rim to the corneal surface can be measured. This study was of interest because it showed the clinical variability between different observers, as much as 5 millimeters by different clinicians on the same day for the same patient. So you have to take this into account if you see different measurements by different clinicians and not assume the disease is necessarily getting better or worse. With regards to diplopia, extraocular muscle involvement is common in thyroid disease, estimated in about 15% of cases. And the most common muscle involved is the inferior rectus, leading to an upgaze restriction. You can remember the mnemonic, I'm slow, to remember the frequency of involvement of each extraocular muscle, with the inferior being more commonly involved in the medial, more common than the superior, more common than the lateral, and the obliques are infrequently involved. Vertical strabismus and esotropia are common. Exotropia is uncommon in thyroid eye disease. And inferior rectus involvement can result in hypotropia, esotropia, and excyclotorsion related to the secondary and tertiary effects of the inferior rectus muscle. So note that torsion does not necessarily indicate oblique involvement, since they're less commonly involved in thyroid eye disease. In a tight inferior rectus, although it most commonly causes hypotropia, remember to think about the potential for excyclotorsion. Compressive optic neuropathy is uncommon, less than 5% of cases, and involves compression of the optic nerve at the orbital apex by enlarged extraocular muscles and orbital fat, hypertrophy, and edema. It manifests with a loss of acuity, color vision, and visual field defects are often central, secocentral, or paracentral. An efferent pupillary defect may be present when one eye is primarily affected. Decreased color vision is often an early indicator. The optic disc may be edematous, pale, or normal. And in the right photo, you see compression of the optic nerve at the orbital apex by enlarged extraocular muscles. Diagnostic testing can consist of thyroid function tests, a TSH, a free T4, and free and total T3. The TSH is usually low, since most cases are associated with hyperthyroidism. The free T4 is usually high, and the T3 may be high. Thyroid antibody tests may be performed, though are not usually necessary to make the diagnosis. The thyroid stimulating immunoglobulin is the most specific of these. Consider evaluation for myasthenia if there are atypical features such as ptosis or a variable strabismus, or if you see exotropia, as this is less common in patients with thyroid eye disease. Myasthenia gravis and thyroid eye disease occur more commonly together. Ultrasonography is often useful for adjunct testing and may be ordered as an A scan and B scan. This test typically shows enlarged extraocular muscles with typically normal tendons. The advantage is the low cost, the lack of radiation, a short exam time, the disadvantage being a need for skilled personnel. I use ultrasonography in my practice, and this is a typical report that I'll see where you see the measurements of the thicknesses of the muscles and the differences eye to eye. You'll also see a note here that the tendons are of normal thickness, which is usually the case in thyroid eye disease. And on the right, you see normal ranges. CT scans may also be ordered. They're very sensitive in showing enlarged muscles and apical crowding. They're quick and widely available and relatively inexpensive. There's good visualization of soft tissue and bone if orbital decompression is anticipated. But remember that compressive optic neuropathy is based on clinical and radiographic findings rather than the latter alone. A disadvantage is ionizing radiation, particularly if repeat scans are going to be needed, and especially in children. The MRI scan gives a better image of soft tissues and is superior to the CT scan if you suspect a non-thyroid eye disease orbital inflammation, such as lymphoma. It's more helpful than CT in showing disease activity, but it is more costly and their longer scan times are needed and it may be less available. Both CT and MRI scan do show tendon thickening in up to 6.4% of thyroid eye disease patients. And here you see a little bit of tendon thickening in this scan, though this is less common. How do you grade thyroid eye disease in terms of clinical activity? Well, one method is called the clinical activity score. And on initial evaluation, these 7 items are scored as 1 point each, with scores of 3 to 4 or more on initial evaluation, generally an indicator of active inflammation. And note in this patient, in his right eye, there is inflammation of the carbuncle, the 7th item in this list. On subsequent visits, changes in proptosis, ocular motility, and acuity are also graded. There are different classification schemes, and this is the European classification scheme for thyroid eye disease, which involves 3 stages. 1, severe or sight-threatening thyroid eye disease, where there is optic neuropathy or corneal breakdown and warranting immediate intervention. The 2nd stage is moderate to severe, where there's no sight-threatening problem, but there is a significant impact on the daily life of the patient, such as diplopia. And then the last category is mild thyroid eye disease. And these patients have very mild problems, which have only a minor impact on their activities of daily living. So what is the differential diagnosis for extraocular muscle enlargement? These include orbital pseudotumor, carotid cavernous fistula, inflammatory orbitopathy, orbital myositis, orbital tumors, and IgG4 disease. These should all be considered when you're thinking of an inflammatory orbitopathy, which may include extraocular muscle involvement. And this is a patient that has metastatic melanoma involving the right inferior rectus. The clinical course, this condition often may occur concurrent with a diagnosis of thyroid disease, but it can occur before or later. And oftentimes the diagnosis may not be made until after the thyroid disease is diagnosed, on average about 18 months after a diagnosis of hyperthyroidism. The acute inflammatory phase may last for 1 to 1.5 years, then it's followed by a chronic non-inflammatory phase. Treatment. Well, let's talk about medical and non-surgical treatment first. First, you want to counsel your patients to stop smoking, since smoking has been shown to worsen the active phase of the disease. I want to recommend artificial tears for exposure Prisms may be indicated in some patients. Mild thyroid eye disease may improve with over-the-counter selenium, 100 micrograms twice daily for 6 months. It's unclear if this benefit is only in those who are selenium deficient, since the randomized trial reporting on this drew from a region known to be high in selenium deficiency, but it's inexpensive and has few adverse effects, and so it's reasonable to treat even in those who are not selenium deficient. Next is orbital radiation treatment. This has been controversial in the medical literature with mixed results reported. Some studies do support a combination of steroids and radiation treatment. You do want to avoid this in those with diabetes who are pregnant or less than 35 years of age. Next are steroid-sparing agents such as methotrexate, cyclosporin, azathioprine, and mycophenolate. These drugs have shown mixed results and are not routinely used. Next is corticosteroids, which we'll spend some time discussing, and the newest modality, teprotumumab. With corticosteroids, oral prednisone can be used, but side effects are common. Can't be used for prolonged periods of time. There's difficulty tapering treatment and rebound of inflammation on discontinuing it. IV methylprednisolone over a 12-week period may have a better risk-benefit profile and consists of treatment of 500 milligrams weekly for 6 weeks, followed by 250 milligrams IV weekly for 6 weeks. The main risks of high-dose corticosteroids include hyperglycemia, hepatic injury, and mental health effects, but side effects may be numerous. Teprotumumab is the newest therapy for thyroid eye disease. It's the only treatment for thyroid eye disease approved by the Food and Drug Administration. Clinical trials on which the approval were based were for clinically active disease with a clinical activity score of 4 or more, which we reviewed earlier, though the FDA actually approved it for thyroid eye disease in general without reference to severity or clinical activity. The magnitude of the benefit with chronic disease is unclear, though some post-approval data suggest it may help some patients. The treatment is given with intravenous infusion every 3 weeks for 24 weeks. But relapse rates after 72 weeks have been reported as high as 40%. Common side effects include muscle spasm, nausea, hyperglycemia, and hearing impairment, and it may exacerbate inflammatory bowel disease. The big disadvantage is a considerable cost. $343,000 for a 24-week treatment for a 150-pound patient, and the cost may go up from there since the dosing is based on weight. How does it work? Well, thyroid-stimulating immunoglobulins are produced, which attach to the TSI receptor on orbital fibroblasts. And the IGF-1 receptor is intimately linked to the TSH receptor in orbital fibroblasts. The TSIs attach to this complex and stimulate the orbital inflammatory process and production of hyaluronan in the extracellular matrix. Teprotumumab attaches to the receptor and blocks the effect of the thyroid-stimulating immunoglobulins. Among patients with active thyroid eye disease, teprotumumab resulted in better outcomes with respect to proptosis, the clinical activity score, diplopia, and quality of life compared to placebo. Diplopia response was for improvement of at least 1 grade, subjectively rated from no diplopia to intermittent diplopia and constant diplopia and constant diplopia. This is the results of a phase 3 multi-center randomized double-masked placebo-controlled trial, which was funded by the producer of this medication, Horizon Therapeutics. Orthoptic management is important in patients with diplopia and thyroid eye disease. Prism correction may be utilized as a permanent treatment for small angles of strabismus or as a temporizing measure while awaiting surgery. And Fresnel prisms are useful for unstable strabismus or incontinent strabismus, where a different prism is needed for distance and reading. Separate distance and reading glasses may be useful when a chin-up head posture is needed to fuse at distance, to avoid having the patients look through a bifocal. Occlusion is another option until surgical intervention. Surgical intervention for thyroid eye disease consists of these three options: orbital decompression during the acute phase for vision threatening, compressive optic neuropathy or severe exposure keratopathy, and in the chronic phase to reduce proptosis. Strabismus surgery is done in the chronic stable phase for large angle strabismus and diplopia, not amenable to prism correction. And then eyelid surgery is done for eyelid retraction. And these three options, when necessary, are done in this particular order for reasons we'll discuss in a moment. Well, we're not going to focus specifically on the special considerations involved with strabismus surgery and thyroid eye disease. So first, remember that the strabismus in thyroid eye disease is restrictive. Most commonly involved is the inferior rectus, followed by the medial rectus muscle. Remember, the Parkes 3-step test is not valid for restrictive disorders, so it shouldn't be used in these cases. There should be 6 months of stable euthyroidism, and the angle of strabismus should be stable for 6 months with no active inflammation before considering strabismus surgery. And you need to wait at least 2 to 3 months between strabismus surgeries, as the effect of recessions may increase up to 6 weeks after surgery. Fresnel or permanent prisms may be used for small angles of strabismus or while awaiting surgery, and significant torsion may require occluding one eye while awaiting surgery. Different approaches have been utilized for orbital decompression. Probably the most common are the medial and inferior orbital wall decompressions. Esotropy may occur and be exacerbated after a medial wall decompression. And A-pattern strabismus and encyclotorsion have been described after inframedial orbital decompression due to increased superior oblique tension related to downward movement of the eyes. So you have to be careful recessing the inferior rectus in the latter case, as you may worsen the encyclotorsion and A-pattern and may need to consider recessing the superior oblique tendon in these cases. What does the literature say about orbital decompression and strabismus? Well, there's a large variability of reports of induced or exacerbated strabismus after bony decompression, between 30 and 50%. Another study reported that orbital decompression patients were 4 times more likely to need strabismus surgery for complex vertical and horizontal strabismus. And another study reported success rates for strabismus surgery are lower after orbital decompression. And if the reason for orbital decompression was vision threatening, the post-op strabismus was worse and more likely. And finally, fat-only decompression carries a lower risk of strabismus, but it's a less robust procedure than bony decompression for sight-threatening disease. What causes the induced strabismus after orbital decompression? One, asymmetric herniation of orbital contents is a possibility. There's a change in position of the muscles and occasionally entrapment of the muscles. And what are the radiographic findings after orbital decompression? You may see first in the photo on the left, the position of the shift in the medial rectus muscles after orbital wall decompression. And in the photo on the right, you see asymmetric herniation of orbital contents after medial and inferior orbital wall decompression. Leaving the floor strut intact reduces the risk of a secondary strabismus with inferior wall decompression. Well, in conclusion, prior orbital decompression is associated with more strabismus surgeries per patient and a trend towards a lower success rate for strabismus surgery. But we can still be successful and make our patients happy, as seen in this patient on the right, both before and after orbital decompression surgery and subsequent strabismus surgery. Well, how about the capsulopalpebral fissure and lower lid retraction? We know that large inferior rectus recessions are often necessary in thyroid eye disease, and they may cause lower lid retraction due to the attachment of the inferior rectus to the lower lid retractors. Dissecting the inferior rectus muscle from the lower lid attachments may be helpful. But I found over time that dissecting the lower lid attachments where the head of the capsulopalpebral fascia attaches to the inferior rectus is helpful, but it's not always as satisfactory as I liked. So particularly for larger recessions, I've begun using this approach described by Kushner in this article, and have been much more happy with my results in minimizing lower lid retraction after inferior rectus recessions. Well, the head of the capsulopalpebral fascia is usually about 14 to 15 millimeters from the limbus, or about 7 to 8 millimeters from the insertion of the inferior rectus. So after dissecting the inferior rectus, I place a 6/0 suture through the capsulopalpebral fascia before dissecting it off of the inferior rectus muscle. And then I reattach that capsulopalpebral fascia at the same position on the inferior rectus muscle before closing the conjunctiva. So if I've recessed the inferior rectus muscle 5 millimeters, in a typical case, I may be reattaching the fascia about 2 millimeters from the new insertion of the muscle before closing the conjunctiva. This technique works well for patients when you're doing a large inferior rectus recession, regardless of whether it's thyroid eye disease related or not. The patient I'm showing you here had a left inferior rectus recession of 5 millimeters. You can see the eye is still slightly red in the early postoperative period, and you see no lid retraction. So what are some general strabismus surgery considerations? Well, your goal is to restore single binocular vision in the primary and reading positions. You want to do forced duction testing under anesthesia to help you understand the amount of restriction of each muscle. And you want to measure torsion with a double Maddox rod, because this may help you in preoperative planning, as excyclotorsion is common with tight inferior rectus muscles. So what are some other general considerations? Well, generally you want to perform recessions rather than resections to relieve restriction, although resections can be performed after you've performed a recession. Inferior and medial rectus recessions are the most common procedures. And typically larger recessions are necessary to relieve smaller deviations, and smaller recessions tend to work better for larger deviations than the standard tables, though the results definitely vary. And here you see a standard surgical table for strabismus, and these are not typically reliable for thyroid eye disease. Well, how do you decide which muscle to operate upon? Well, first you want to look at the eye position and the primary position. And if you have a scan, that helps, as we do in this case, but it's not always necessary. This case suggests a tight left medial rectus muscle. And so what you see on the scan of the same patient on the right is a large left medial rectus muscle. So I'd recess that first. You also see the inferior rectus muscles are enlarged, but symmetrically. And in this case, the patient had a symmetric limitation of upgaze and did not need surgery on the inferior rectus muscles. We also want to look at someone's ductions and inversions, and I discussed performing forced duction testing in the OR to help with surgical planning. And here's an example of examining inversions in a patient with thyroid eye disease. So in the primary position, you see a left hypotropia and suspect that the left inferior rectus muscle may be tight. And this is confirmed on version testing with limitation of elevation of the left eye, which is greatest in abduction, and overaction of the left inferior rectus in abduction. So I would recess the left inferior rectus muscle in this case after confirming with forced duction testing in the operating room. And again, I've mentioned the importance of doing forced duction testing under anesthesia in the OR. Is the problem primarily restriction of the right inferior rectus muscle in this case, or is it a problem with the left superior rectus? So after examination in the office, forced duction test in the OR may be useful in surgical planning. Well, I mentioned earlier that the standard strabismus dosing tables are typically not reliable in thyroid eye disease since the muscles are abnormal. Well, people have looked at dose response tables, and they can be developed in individuals with thyroid eye disease, but the results can be very different from patient to patient. And here you see in the table on the right that whereas an average inferior rectus recession gets you 3 prism diopters or so per millimeter at distance and 2.5 at near, the results can vary quite a bit from patient to patient. So you see, for example, in the table on the right from this article, of patients that had an inferior rectus recession of 5 millimeters had results varying about 60 prism diopters from patient to patient. So what else have people utilized to help them determine the amount of surgery to perform? Here are another couple of methods which have been suggested which do not use adjustable sutures. In the first, there's a matching of restriction of ductions between the two eyes. So in the first method, you rotate the contralateral globe to its maximum point of rotation, achievable, and in this position, the muscle to be recessed on the operated eye is attached to its point of resistance and sutured to the globe, matching restriction of ductions. In the second technique, there's an intraoperative relaxed muscle positioning. Here you relocate the muscle insertions in their relaxed state. The globe is positioned with the AP axis perpendicular to the frontal plane, so in the primary position, and the point of attachment of the muscle is where the position of the muscle rests freely on the globe. And adjustable sutures would seem to be a natural indication for use in patients with unpredictable surgical outcomes, but you have to be careful here because late overcorrections can occur due to the increasing effect of recessions after surgery, which could be due to an issue with adherence of a tight muscle to the globe or long-term changes in the antagonist contracture. So authors have recommended considering use of non-absorbable sutures in these cases or considering undercorrection in the immediate post-op period. Say by 6 to 8 prism diopters when performing an inferior rectus recession in the immediate post-op period. What are some other considerations? Well, bilateral medial rectus recessions carry a greater risk of consecutive exotropia if the lateral rectus is involved in thyroid eye disease. Here's a consecutive exotropia by medial rectus recessions. An A-pattern exotropia and downgaze may occur after bilateral inferior rectus recessions and may be exacerbated by medial rectus recessions. Excyclotorsion may be addressed by recession of tight inferior rectus muscles. But remember that large recessions may induce encyclotorsion, and in complex cases, it may be preferable to stage the surgery. Use of grooved muscle hooks can make the surgery technically easier, and these have saved me in many cases of strabismus cases with tight muscles and thyroid eye disease. They help reduce the risk of scleral perforation on needle passage and reduce the tension necessary to place sutures in the muscle. and may reduce the risk of the pulled-in-two syndrome or PITS. There are several options for consideration: the right grooved hook, Koval hook, and the Bishop hook. Well, in conclusion, thyroid eye disease is challenging to manage for strabismus specialists, and familiarity with the unique aspects of strabismus related to this condition will help improve outcomes for our patients. Hopefully, new medications will improve our ability to manage this complex condition.